السلام عليكم. أنا دكتور عقيل. أرجو أن يكون الجميع بخير وصحة وعافية. And I will talk in this lecture about the spinal cord disorders. As you know, the spinal cord is part of central nervous system, and it is a continuation of medulla oblongata in the brainstem. So, it serves as a conduit for information traveling between the brain and the peripheral nervous system. The spinal cord terminates at the level of L1, L2 vertebrae, which called conus medullaris. From the conus medullaris, nerve fiber continue down to form what we know as cauda equina, or the horse tail. The spinal cord goes through the spinal canal, which is basically made of vertebrae, and the vertebrae divided into 7 cervical vertebrae, 12 thoracic, 5 lumbar, 5 sacral, and also we have coccyx. The spinal cord divided into segments. Each spinal cord segment have nerve is coming in and out of it, and these are known as spinal nerve. The spinal nerve exits from their corresponding vertebral level. The cervical level is unique. Why it unique? Because it had 8 pairs of spinal nerve. So the cervical spinal nerve exits over the corresponding vertebral level. Example C1, the spinal nerve goes over the first cervical vertebrae, and the cervical 8 segments exit above the first thoracic vertebrae. While in the thoracic level, the thoracic segment have 12 pairs of spinal nerve, and it exits below the corresponding vertebral level. Example T1 exits below the T1 vertebrae, and the lumbar also has 5 pairs of spinal nerve, and also it is exit below the corresponding vertebrae, and so on till we have finally coccygeal nerve, which exits below the coccyx. In this cross section, you see that the spinal cord have centrally butterfly-looking structure, which is the gray matter, and this contains the cell bodies. And the peripheral part is the white matter, which contain the axons. And the spinal cord has 2 roots, the dorsal root into the back and the ventral root in front. Together will form the spinal nerve. This slide shows you the ascending and descending pathways of the spinal cord. The ascending pathway carries the sensory information from different parts of the body and goes up through the brain stem to the thalamus and then to the cerebral cortex. The sensory information which come from lower part of the body below the level of T6 go to the gracilis fasciculus, while the sensory information from upper part of the body above T6 will go to the cuneate fasciculus, which is just lateral to the gracilis fasciculus. So the ascending pathway of the spinal cord includes the posterior column, which carry the proprioception, vibration and position sense with fine touch and 2-point discrimination, while the other ascending pathway, which is the anterolateral spinothalamic tract, carries the pain and temperature with crude touch, and the descending pathway, which gives the motor order from the brain to the different part of the body, includes the anterior corticospinal tract and the lateral corticospinal tract. Now, What are the clinical signs and symptoms of the spinal cord lesion or disease? The first symptoms is the motor, and also we have sensory symptoms and signs. Also, we have pain and autonomic disturbances. First, we discuss the motor sign and symptoms of the spinal cord lesion. So, it divided into upper motor neuron lesion and lower motor neuron lesion. And these differences, we must know the differences between sign and symptoms of upper and lower motor neuron sign. The weakness in the upper motor neuron lesion more diffuse, and it is have a characteristic features which is called pyramidal weakness. The pyramidal weakness is that in the upper limb, the flexor muscle more powerful than extensor muscle, while in the lower limb, the extensor muscle more powerful than flexor muscle. And this is called pyramidal weakness, which is a first sign of upper motor neuron lesion. While in the lower motor neuron lesion, the weakness is more focal, and it's either proximal, distal, or both proximal and distal. The atrophy second sign of spinal cord lesion in the upper motor neuron lesion will be mild and maybe general, while in the lower motor it is severe, focal, and part of disease. Fasciculation, never seen in the upper motor neuron lesion, while may be present in the lower motor neuron lesion. The muscle tone in the upper motor neuron side will be increased and it is called spasticity, while in the lower motor neuron lesion, the muscle tone will decrease, hypotonia. The reflexes are increased in the upper motor neuron lesion, hyperreflexia, and may be present with the clonus, while reflexes in the lower motor neuron lesion is decreased or diminished and or absent. Babinski side, upgoing or positive may be present in the upper motor neuron side, while absent in the lower motor neuron lesion. The second symptoms is pain, and you must know what are the difference in character of pain between extramedullary and intramedullary lesion. You know the extramedullary lesion, which is extrinsic lesion, while the intramedullary is inside the spinal cord and it is called intrinsic lesion. You know extramedullary lesion cause pain which are radicular pain or stabbing, shooting, electrical like pain, while in the intramedullary lesion, the pain is arising inside the spinal cord, more diffuse pain or no pain at all. Now we discuss the third clinical sign and symptom in the spinal cord lesion, which is sensory symptoms and sign. The first thing you must know what is dermatome. The dermatomes are sensory nerve fiber innervate a segment of skin and is associated with a single spinal cord level. So the sensory symptoms and sign is very important in localizing the lesion of the spinal cord. The spinal cord lesion cause sensory level according to the site of the lesion within the spinal cord, and it is either dermatomal as in the lesion at the level of C4, which cause sensory symptoms at the clavicle, while at the nipple the level is T5, umbilicus T10, while in the inguinal region L1 and so on. If the lesion affects the posterior or dorsal column of the spinal cord, so the impairment will be in the proprioception sensation and fine touch. And if the lesion affects the spinothalamic tract, it will cause the impairment in the pain and temperature. And there is important thing here, the proprioception, if affected in the spinal cord, it will be ipsilateral uh, proprioception affection, while the spinothalamic tract will be contralateral to the lesion in the spinal cord. The autonomic disturbance of the spinal cord lesion, it will consist of neurogenic bladder, like urgency incontinence retention, or bowel dysfunction like constipation, nausea, vomiting, or fecal incontinence. There is something important here. If the spinal cord injury at the cervical level, it implies serious disturbance in the acute phase, the autonomic imbalance, and its effect on cardiovascular respiratory system and temperature regulation. What are the spinal cord disease? You know the spinal cord disease may be inflammatory demyelinating or vascular disease or degenerative disease or a tumor. We start here with the inflammatory demyelinating disease of the spinal cord, which is consists of multiple sclerosis, neuromyelitis optica, subacute combined degeneration of the spinal cord like vitamin B12 deficiency. I start with the neuromyelitis optica because the multiple sclerosis, we discuss it in its own lecture, in another lecture. So, neuromyelitis optica is also known as Divik disease or Divik syndrome. From its name, it's a neuromyelitis optica consisting simultaneous demyelination of the optic nerve, which cause optic neuritis, and the spinal cord, which cause myelitis. So it is an autoimmune disorder in which white blood cells and antibodies primarily attack the optic nerve and the spinal cord. And neuromyelitis optica common in women than men, and it occurs at any age, at any group, and in children as young as 3 and adult as old as 90, but typical age between 40 and 50 years. Basically, the diagnosis of NMO requires evidence of optic neuritis and transverse myelitis. There is additional finding that support the diagnosis of NMO, like lithium lesion of the spinal cord. And the lithium lesion of the spinal cord mean elongated, extensive, longitudinal lesion affect more than two segments of the spinal cord, which is seen by MRI image. Another finding in the MRI brain, which do not meet the criteria of multiple sclerosis, also support the diagnosis of NMO. Examination of the LP CSF analysis for the protein, cells, and different aquaporin and aquaporin 4 antibodies support the diagnosis of NMO. Blood test for NMO antibodies like aquaporin and antibody aquaporin 4 antibody and anti-MOC antibody. Also, these are supportive the diagnosis of the neuromyelitis optica. This slide shows you the neuromyelitis optica affect the spinal cord, and you see in this picture the elongated extensive lithium lesion which involve more than two segments of the spinal cord. Early diagnosis and treatment of NMO is very important because NMO is extensive disease and may lead to severe, serious neurological sequelae. Till now, there is no medication have been specifically approved to treat NMO, but the standard care is for initial attack. So the treatment of initial attack of NMO is treated by IV intravenous methylprednisolone 1 gram per day for 5 days, followed by 10 days taper oral prednisone. If there is no improvement, so here plasma exchange is indicated. Plasma exchange or plasmapheresis is indicated if there is no response in the patient who taken IV methylprednisolone for 5 days. And you must do 5 sessions of plasma exchange. And this is the treatment of attack. While the maintenance therapy for treatment of NMO or long-term therapy for the treatment is consist of either mycophenolate mofetil, silicet tab, or rituximab injection or azathioprine tab. Subacute combined degeneration of the spinal cord is a rare neurological complication of vitamin B12 deficiency that lead to demyelination of the dorsal and lateral spinal cord and corticospinal tract, and it is either due to malabsorption secondary to pernicious anemia or surgery or insufficient dietary intake. The early commonest sign is the megaloblastic anemia. Clinically, subacute combined degeneration of the spinal cord characterized by dysesthesia, either peripheral polyneuropathy, affection of proprioception impairment, and spastic paraparesis or tetraparesis due to affection of the corticospinal tract. This slide shows you MRI image of the spinal cord, which shows that the lesion affect the dorsal and dorsolateral part of the spinal cord due to vitamin B12 deficiency, which lead to subacute combined degeneration of the cord. Vascular lesions of the spinal cord, it consists of either ischemic lesion, AV malformation, cavernous malformation. The spinal cord is supplied by anterior spinal artery, posterior spinal artery, and segmental arteries. The anterior spinal artery occlusion lead to anterior spinal infarction, which we call it anterior two-third syndrome. It's occurred due to atherosclerosis or surgery, during surgery in which aorta is clamped, or due to dissecting aortic aneurysm. Clinically, it presents with loss of motor function, tetraplegia or paraplegia according to the level of the occlusion, and also impairment of pain and temperature sensation with relative sparing of proprioception and vibration sense below the lesion. This slide shows you the anterior two-third syndrome, which is the anterior infarction of the spinal cord. Arteriovenous malformation of the spinal cord is rare, but the diagnosis is important because this lesion may represent a reversible cause of myelopathy. The AVM in or around the spinal cord cause cord compression, ischemia, or hemorrhage, and the treatment is with stereotactic neurosurgery. This slide shows you the AV malformation of the spinal cord at different levels. As we said, the treatment is by stereotactic neurosurgery. Spinal cord tumor. There are three common types of spinal cord of spinal tumor that can cause different sign and symptom of a spinal cord lesion. The first is vertebral column tumor like metastatic tumor or primary. Extramedullary tumor, which is include either intradural or extradural tumor. Intradural like meningioma, schwannoma, neurofibroma, and extradural dural is either from the bone, osteosarcoma, or metastatic from the prostate or kidney or breast. Intramedullary tumor, which inside the spinal cord, like astrocytoma, ependymoma, hemangioblastoma, and also metastatic spinal cord tumor from other side. This image shows you that there is intramedullary secondary metastasis to the spinal cord from colonic carcinoma. This slide shows you different signs and symptoms of extramedullary and intramedullary lesion and how to differentiate between extramedullary and intramedullary lesion. Start by history. In the extramedullary lesion, the onset is asymmetrical while intramedullary is symmetrical. The pain is local or radicular in extramedullary lesion while it is funicular or tract pain in the intramedullary. In motor, the upper motor neuron sign is early with extramedullary while late in the intramedullary lesion. The lower motor neuron sign in the extramedullary lesion is segmental while with intramedullary is diffuse. Sensory involvement in the extramedullary lesion is in ascending pattern from below up, while in the intramedullary lesion is descending in fashion. The autonomic sphincter involvement is late in the extramedullary while early with intramedullary lesion. Infection of the spinal cord starts with poliomyelitis, a disease caused by virus, and it affects children younger than 5 years old are more likely to contract the virus than any other group. The signs symptoms are purely lower motor, such as loss of reflexes, hypo or diminished reflexes, severe spasm or muscle pain, loss of power, sometimes on just one side of the body, sudden paralysis, and deformed limb, especially the hip, ankle, and feet in long term of the disease. Another infectious disease of the spinal cord, what we call it neurosyphilis, tabes dorsalis. It refers to nervous system involvement by infection with syphilis. It is at first affect the lumbosacral dorsal root, which is infected and inflamed, produce severe radicular pain in the lower limb. The posterior column degenerate, cause impairment of vibration and position sense, reflexes is lost. The strength remain intact since the motor neuron and corticospinal tract are spared. The third infectious disease of the spinal cord is HIV myelopathy, which causes myelitis of the spinal cord. It is mimic the B12 deficiency, is superimposed with different multiple another brain or brainstem or peripheral nervous system signs and symptoms like peripheral polyneuropathy, encephalitis, and so on. Tropical spastic paraparesis, or what we call it HTLV1 myelopathy, is a slowly progressive viral immune-mediated disorder of the spinal cord caused by HTLV1 virus. It causes spastic weakness of both legs, and the diagnosis by PCR test of the serum and the CSF, and the treatment, supportive care, and possibly with immunosuppressive drugs. Transverse myelitis is an inflammation of the spinal cord with many causes, and it affects people at any age, gender, or race. The causes remain unknown in many cases, but it may be due to either immune system disorder like multiple sclerosis or neuromyelitis optica, post-infectious myelitis or post-vaccination myelitis, infection like viral, bacterial, fungal, and parasitic infection, inflammatory disease like SLE, Sjogren disease, sarcoidosis, and Behçet, vascular myelitis due to infarction, AVM, or AV fistula. And we will talk about the transverse myelitis in detail in another lecture. Brown-Séquard syndrome refers to cord hemisection and mostly caused by trauma or tumor. Clinically, it causes ipsilateral upper motor neuron sign, ipsilateral posterior column sign, affection of the proprioception, like vibration and position sense, while it causes contralateral spinothalamic tract sign, like pain and temperature sensation impairment. Syringomyelia is a cavity in the center of the spinal cord, the cervical cord most common site, and it may occur at a late sequelae of the trauma. Clinical sign of the syringomyelia, it causes weakness of the muscle in the arm and atrophy with hyporeflexia. Later, affection of corticospinal tract lead to weakness and spasticity with hyperreflexia in the lower limb, and the sensory loss is as cape-like shape and can be seen in association with Arnold Chiari malformation, and the treatment of syrinx is by surgery. This slide shows you the syringomyelia of the spinal cord, which, as we said, the treatment of this needs surgery. As we said at the beginning of the lecture, the spinal cord ends at the level of L1, L2 lumbar vertebrae and cause a bulbous part of the spinal cord called conus medullaris. And this conus medullaris, from this side, a collection of nerve roots which are horsetail-like in appearance, and this called cauda equina. Patient can present with signs and symptoms of isolated cauda equina syndrome or isolated conus medullaris syndrome or in combination. And you must know that the symptoms and signs of cauda equina syndrome tend to be mostly lower motor in nature, while those of conus medullaris syndrome are a combination of lower motor neuron and upper motor neuron lesion sign. This slide shows you a conus medullaris lesion due to lipoma at the end of the spinal cord, and the other picture shows you that cauda equina lesion due to severe rupture intervertebral disc. In this table, I show you the difference between conus medullaris and cauda equina syndrome at different presentation or sign and symptoms. So at the presentation, the conus medullaris lesion is sudden and bilateral, while the cauda equina is gradual and unilateral. The pain is less severe in conus medullaris lesion, while is more severe in the cauda equina lesion. The low back pain is more in the conus medullaris, while less in the cauda equina. The motor strength or power, typically symmetrical, distal to the paresis, marked hyperreflexia, fasciculation may be present in the conus medullaris, and as we said in the previous slide, the conus medullaris causes combination of upper and lower motor neuron side, while the motor strength in the cauda-equina syndrome is asymmetric and areflexic, paraplegia, atrophy, and fasciculation is rare. The sensory symptoms and signs tend to be in the conus medullaris numbness, more localized to perianal area, and symmetrical. Bilateral sensory dissociation occur, while in the cauda equina, the numbness tends to be more localized to saddle area, asymmetrical, and may be unilateral, no sensory dissociation, and loss of sensation in a specific dermatome in the lower extremities, with numbness and paresthesia, possible numbness in the pubic area, including glans penis or clitorius. Reflexes, the knee jerk is preserved in conus medullaris, but it affected ankle jerk, while in cauda equina, both ankle and knee jerk are affected. Impotence is frequent in conus medullaris, while it is less frequent in the cauda equina. Erectile dysfunction that include inability to have erection, inability to maintain erection, lack of sensation in pubic area including the glans penis and the clitorius, and inability to ejaculate. Sphincter dysfunction, urinary retention, and atonic anal sphincter, which cause overflow of urinary incontinence and fecal incontinence. These tend to be present early in the course of the disease that affect conus medullaris syndrome, while it will be late in cauda equina lesion. The investigation used for the diagnosis of spinal cord disease includes radiographic examination like plain X-ray, myelography, CT angio, MR imaging. The second is LB if you suspect inflammation like MS, rupture AVM. Also, there is another blood test for antibodies in the CSF or in the blood to diagnose or exclude other disease of the spinal cord like neuromyelitis optica. Lastly, there are other diseases affect the spinal cord like hereditary spastic paraparesis and usual hereditary disease, autosomal dominant, and it is a purely motor. Infections of the vertebrae like TB or bacterial infection, herniated intervertebral disc with cord compression, mostly lateral herniation and only compressed a nerve root, degenerative disease of the vertebrae like cervical spondylosis with myelopathy or spinal canal stenosis. Thank you for listening.